Hello, I'm Eric Topol, Editor-in-Chief of Medscape, and I'm really delighted today to welcome Dr. David Feinberg, who heads up the Geisinger Health System, to join me. David, great to have you on Medscape with us.
Well, thanks so much, Eric. I'm excited to look forward to our conversation.
Well, I just was going to give a little bit of background. Let me make sure I've got it right. You were at UC Berkeley, Chicago Med School. You got an MBA from Pepperdine, and then eventually became the CEO of the UCLA Health System. Is that right?
That's right.
And you made a big switch, moving from LA to Geisinger, what, 3.5 years ago. What was that like to make this big from LA to Danville, Pennsylvania?
Well, first of all, UCLA is just an amazing organization. I did my residency and fellowship there, and I don't think I was ever leaving UCLA. But I had sent a team to Geisinger a couple of years before because everyone was talking about Geisinger, and that team came back and really changed how we actually provided neurosurgical services at UCLA. And then a couple of years later, Geisinger calls and says, "Hey, we're looking for a chief executive." And I thought I would just go to learn more about Geisinger so I could bring it back to UCLA. And what I found during that exploration phase was all the stuff that Geisinger had, I felt like I could get to UCLA, but it would take 10 or 15 years, and it would be the end of my career. Or could I go to a place that actually had all the tools and see what could happen? So it was this really, actually my wife and I probably did, this was before people were doing 10,000 steps. We'd do 10,000 steps every night, talking, why are we moving? Why should we do this? Should we do it? Should we not do it? I had never had another job other than UCLA. And then I came to Geisinger, made that decision. And I got to tell you, it's amazing. First of all, I feel liberated in that Geisinger has only one mission. Unlike an academic medical center that's worried about research and academics and teaching and clinical care, and oftentimes they say the community. At Geisinger, our only focus is the community. It's the people that we serve. So you kind of have the freedom from that academic medical center piece, and it has all the tools. So we have, now we have a medical school, but we have an insurance company, we have a very strong clinical delivery system, and we have 33,000 people that get up every morning and try to make it better for our friends and neighbors. And so it's been incredible. And then, from a personal standpoint, when you're in the echo chamber of West Los Angeles and we were living in Beverly Hills, we now live in the other America. And it's very rural and it's very poor. And things that are happening in our country make much more sense to me now than had I not had this opportunity. So it's been a privilege to move to the middle of Pennsylvania.
Well, that's fantastic. And we're going to talk about some of the things you're doing there that are truly things that are unique on the planet, the most progressive health system I know anywhere. So that is a real credit to what you've been doing. But before we do that, I wanted just to, this quote I have of yours is this one I just love. I have to say, I think our industry is so screwed up and is ripe to be disrupted. Either we do it or some Stanford dropout in a black turtleneck is going to. That one really hit me as a person who truly gets it. And the things I wanted to get into as far as disruptive, one of the ones that's most extraordinary is the recent efforts, not just the genomics that you did in collaboration with Regeneron, with a couple of 100,000 of the patients at Geisinger, but your announcement of doing that much more broadly in all the patients of Geisinger who are interested. Can you tell us about your view of genomics and where it is at Geisinger, where it's headed?
Yeah, so we're taking an approach that's different than others. So there's some organizations that I think are way ahead of us in, sequencing a cancer gene and understanding what medicine to use, or looking at genetics and saying to patients, you should be on this medicine or on that medicine. Our approach, because everything in our approach is population-based, was what if we did whole exome sequencing on our entire population? We started this, as you said, Eric, in partnership with Regeneron, to see could we find medically actionable genetic conditions, predominantly autosomal dominant conditions, that we could do something about. So we're 200,000 patients into it, or we could say research subjects, because we started with research. And we have found that 3.5% to 4% of those people have something actionable. BRCA, malignant hyperthermia, Lynch syndrome, the genes associated with cardiac arrhythmia. We saw a 16-year-old girl in our ER. She comes in, she's dehydrated from soccer. We give her some fluids. She participates in the MyCode study. Turns out she has 2 genes associated with fatal cardiac arrhythmias in young athletes. Because where we are, people don't move, and we've taken care of these people multi-generations, there's 30 people in her family that we care for, that we have electronic records on. We get all the genetics. Turns out 15 out of that 30 have the gene. Now many of them have pacemakers in or on beta blockers or both. Literally saving lives before it happened. So as we did that through a research enterprise, and Regeneron has helped fund this for them to use that information in a de-identified way for drug discovery, we felt we can't wait to turn this on. It was actually our doctors saying to us, I want to do this on all my patients. So I think it's now been about 2 months. We said any one of our patients will do whole exome sequencing on for free. So the same way you would go to your doctor and they would say, you haven't had a mammography, or it's time to check a PSA, or have you had your colonoscopy? Or if you're a kid, we say we'll do whole exome sequencing on you. We get the results in about 2 weeks. We return the results. Our return of results is fascinating. We learned this through when we got started. When you get a positive result, the first thing we do is notify your primary care doctor. Your primary care doctor then clicks the email and gets a 30-minute continuing medical education course on BRCA or Lynch syndrome, whatever the disorder their patient has. So a refresher course. 5 days later, the patient is notified that they had a genetic mutation and is asked to come in and see the doc. So the doc is prepared for the visit, the patient's prepared, and they have a discussion. Because all it is a genetic mutation, right? But the real thing is, should we go to the breast clinic? What do we need to do different based on this information? And we built it into our electronic health record. So it's very easy to have the ongoing surveillance more often for colonoscopies and Lynch syndrome. Whatever it is, it's built in. So very, very easy workflow from our docs.
Have you noticed that the doctors are getting genomified? That is, they're really getting more up to speed because of this program?
No question. So if you look outside, there are places that are saying, I won't meet with you if you come in with a 23andMe result. I think there's certain health systems that are saying that. Ours is the opposite. Our doctor said, we want this now in routine clinical care.
Mm-hmm.
And the way you get the docs, and I think this is so true in many ways, they didn't buy in until they had their first patient. And we learn in this kind of story case-based way. So as soon as a doctor had their first patient with return results, and we prepped them with the right information and they had a positive experience, they became ambassadors for the program. The other thing that we saw, which we didn't anticipate, when we give somebody a genetic result back, a return of result, that doctor the next day gets calls for 6 brand new patients that want to see that doctor. The patient goes home and tells their friends, I have a genetic mutation, and all the friends want to go see the doctor. And
amazing.
The doc had nothing to do with the testing, I mean, with the program, but that we think is important, is that relationship with the doc.
Well, it's phenomenal just because, as you know, David, just the recent review in New England Journal on Lynch syndrome just last week, it's basically pointed that everyone with colon cancer should be screened for Lynch syndrome. Very few actually get that screening unless they happen to be young or some type of anomaly. You're doing the opposite. You're proactively doing this, in patients. And I saw the clip when you were the first patient to enroll in the program. So it's not just you're getting patients, you yourself, isn't that right?
Yeah, so I've had my genome done so many times now because I'm interested in the user interface, and it always comes back with the same things. I got male pattern baldness, but Rogain's working, and I'm actually protected against celiac disease. I could bathe in wheat, so my genome would stay the same. But yes, I did participate. I think it was the 5th time I've done my genome. But it's also, we think, a cost decreaser. So if you think about it, routine clinical care would be now if your parent had colon cancer at an early age. The gastroenterologist would say all offspring should start colonoscopies at age 30 because there's a family history of early on colon cancer. We actually know that actually only half those offspring have the Lynch syndrome mutation and should be started at 30, and the others shouldn't get their colonoscopy until age 50 or whatever the new recommendation is.
Right.
The same with BRCA. So 50% of people that are BRCA positive breast cancer have no family history. Now we know it's a genetic disorder, but maybe mom died of something else, or there's no sister, and they don't have the family tree in their mind. So if they went to a doctor, no one would order BRCA testing on them. We're finding those 50% of BRCA positive people without the family history that are BRCA positive. So we think if you live in central Pennsylvania, we also have a health system in New Jersey, in southern New Jersey and Atlantic City, and you're a young woman, your chances of getting breast cancer are lower here than anywhere in the US because we know who's BRCA positive.
All right. Now, just the size of your system for people who are not so familiar, you have, as you mentioned, some 33,000 employees. And how many patients are you serving in the whole regions that you are working?
We take care of about 3 million folks.
Yeah,
We're about a $7.5 billion organization. We have 12 or 13 hospitals, a lot of outpatients, a lot of helicopters, clinics, docs, and people, and an insurance company and a medical school and research focused on genetics.
Yeah. Now, I wanted to go from genetics, genomics, to another topic that you've been pioneering, and that's the food pharmacy. I think that's particularly set up for diabetics, or maybe beyond that. Can you enlighten us about that program?
Sure. So we think that the way that we think that the most important thing for you to live a long life and to have a lot of life in your years is not what takes place in the hospital, not what takes place in the clinic. That medical care probably accounts to only about 20% of your health outcome. It's the other stuff. So we think it's your genetic code, and we also think it's your zip code. So the same way that we've sequenced DNA, we sequence your zip code. We know everything about where you're living. One of the big issues, and we have others, but one is around food. So we have screened every one of our patients for food insecurity. And food insecurity, you just have to say yes to one of two questions. I'm going to run out of food this month, or I don't think I have enough money for food. Basically, I got food issues. And then we looked at those patients that had food insecurity and also had type 2 diabetes. And those two disorders go together, because if you're food insecure, if you're poor, you buy high caloric, non-nutritious food that creates type 2 diabetes. If you get type 2 diabetes, you miss on average 17 days of work per year, you become more poor. So it's this negative cycle. And so we said, what if we went in, and you may call this innovative, but this guy Hippocrates said this a long time ago, if we use food as medicine, what if we went in early and did diabetic education and gave people the healthy food? So we found patients with hemoglobin A1C, which is basically a measure of blood sugar over the last 3 months. And it should be 5%, 6%, 4%. If it's 7, 8, 9, you're not doing well. And if it's 10, 11, 12, you're really not doing well. We found those patients, food insecure, type 2 diabetes. We bring them in, diabetic education, and then we're really the grocery store. We give them every week 7 fresh fruits, 7 fresh vegetables, whole wheats and grains, and lean meat with recipes. And if they're living in a motel, they get a hot plate and a spatula and a microwave. So we give them all the tools necessary to take care of themselves. And what we found was amazing. Hemoglobin A1C. If you metformin or any of these meds, to get FDA approval, you must decrease hemoglobin A1C by 1 percentage point. And that's what most of you do. We would say kale and quinoa decreases at 2.5 points. We've seen an average of a 2.5 point reduction in hemoglobin A1C.
Wow.
Our medical spend, and now we pick some of the sickest patients to start with, went from around $200,000 a year per patient a few months in the program, and their medical cost drops down to $40,000. So we save $160,000, and it costs us about $1,200 to feed them.
That's extraordinary. What I love here is you've taken, a high-tech approach with getting exomes of hundreds of thousands of your patients, and now what you would consider perhaps a low-tech, which is, fixing the food problem, which I don't know of any health system that's doing that. I mean, this is really an amazing range. Now, those two programs enough set you apart from any other health system on planet Earth, I think there's other things like you're doing. As I recall, there was a program where if you weren't happy, you could get your money back and things like that. I mean, what other things are you up to besides these two big ones?
So let me stick with the social determinants, and I'll tell you about our refund program. So I'm here in Danville. If you live within 50 miles of Danville, we also have a bunch of hospitals and clinics up in Scranton. And if you're 25 miles in Scranton, so basically in our catchment area, and you need a ride to church, to home, to the doctor's office, to your friend, we provide it for free. So we eliminated the transportation issue by just saying, we will transport you wherever you need to go, because we think that loneliness and that isolation is probably as big of a killer as heart disease. So we eliminate the transportation issue. We're in a rural part of America, a lot of Lyme's disease. We know from an environmental standpoint, based on how close you live to the forest, your rates of Lyme's disease, and we feed that information into our primary care doctor's office so you get a Lyme score when they see you. And it's hard to make that diagnosis sometimes, so we're using kind of high-tech predictive analytics around that. The overdose rate where I live, the death rate from overdose from opiates here is 4 times higher than New York City. So we're being ravaged by opiates. We've done a huge work on decreasing our opiates. Starting next month, all elective surgery at Geisinger, all elective surgery will be done opiate-free. And we're using a different method. Instead of, as I was trained, you were supposed to say, don't eat anything after midnight and then we'll do your surgery. We do the opposite. We feed you a high-protein amino acid drink 2 hours before surgery without opiates, so your gut isn't slowed up. We feed you 2 hours after surgery and are going to be completely opiate-free in all elective surgery next month. Our refund program, though, really builds on the history of Geisinger's, focused on the clinical side, getting out the unnecessary variation in care. So it started with hearts. And I think we're so good now at hearts that places like Walmart, JetBlue, McKesson, and Lowe's say if you need heart surgery, spine surgery, bariatric surgery, and you live in this 40% part of the United States, basically the whole eastern US, you can pay 50% of the cost to have your spine done at Arkansas Hospital if you're a Walmart person or wherever they are, or you can go to Geisinger for free. And they send the patients to us with a companion. And the crazy thing is that 40% of the time, we're not operating, and these are people that were scheduled for surgery in their hometown. So we're really good at that. The piece that we added on a couple of years ago was, well, we're really good at the acute care. We're really good at the chronic care. Our anticoagulation is the best. It was best in the United States. It's now become the best in the world. So we're really good at managing people. But I felt that we had to do more. You know, how can we answer the phone every time on the first ring? How can we offer everybody a same-day appointment? How can we make sure everybody treats you with compassion? How can we make sure that the bill we send you is totally understandable, that your transition from inpatient to outpatient is smooth, that every part of your care is exactly what I'd want for my mom? And so we added to that what we call proven experience, because all those other things are called proven hard or proven whatever, proven home. Proven experience is, if there's any part of your care that you're not satisfied with, we offer a no questions asked money back guarantee. You can have all or some or whatever you want of what you paid back. And then we give a little bit of there's a couple fine prints. We do ask questions. We ask your name and address so we can send you the money. But that's the only question we ask. And we've returned millions of dollars to our patients. And they have been the best secret shopper program ever. And they tell us what's working and what's not working. So you can do this with a front desk person. We also have an app. A typical one is a woman will come in for surgery. I just saw one the other day, has surgery, and leaves all kinds of positive comments on the app. Doc was great, nurse was great, etc. But 3 complaints. The IV infiltrated. There was construction on the floor above. We said it would be over at 9 o'clock at night. Where she was, it lasted till 10. And one of the nurses wasn't very kind in helping her to the commode. This woman had paid $2,000 out of pocket for the surgery that she had. She asked for $150 back. And to me, it's worth $150 to find out, hey, how can we get better? And who do we need to compliment because we did well? So that's been our proven experience program of giving.
Wow. Well, it's amazing. I mean, all these things, I don't know any other health system that does this. It's really a model. Now, there must be some downside. Is there something, a challenge, or what do you see? I mean, you are so far removed you're an outlier in such a positive sense that you've been reviewing. Is there something that is holding you back, or that you feel is also a unique negative?
Well, the thing that worries me the most um, is where we are. So we're in a place where the economy is not robust.
Mm,
We're in a place where the young people don't, other than going into healthcare, don't have a lot of opportunity. So that to me, if we become exclusively a provider to government payers, Medicare and Medicaid, because that's all that's left in our communities, it's going to be hard for us to be able to make these types of investments. So my biggest concern is really our economy and the jobs. I mean, when I go into one of our towns to one of our hospitals, and the only restaurant in town is the cafeteria in our hospital, that's a problem to me. I never, ever want to be the biggest employer in any town, right? It just doesn't make sense. We should have a robust economy around us. And we're in a part of Pennsylvania and sometimes New Jersey, because we're in Atlantic City, so it's had its ups and downs, where the vibrancy of the community is something that actually worries me. So that's why we said in Scranton, we're going to make it the healthiest place to live in America. We call it Springboard Health. We're bringing all our programs, our genetics, our food, all that kind of stuff, a lot of community partners. And we think if we can make it the healthiest place to live, it'll actually bring business into the Scranton area, which is really the thing I'm worried about. One of our fresh fruit pharmacy, a few of our fresh fruit pharmacy patients, as they get better medically, one guy told me his blood sugars were in the 300s. 3 months in our fresh fruit pharmacy program, his blood sugars got better. He got his commercial driver's license back. He's now driving again. So it's going to break the poverty. So bad health and poverty are so linked. So we think if we can create health, it'll create economic stimulus. People will go back to work, and that's what we need. So that's the issue. It's different than New York City or Los Angeles or San Diego, for that matter, where you have places that are doing well and places aren't doing well. We're just not doing well from economics.
And the other thing is, this is not just talk for the people at Medscape that are watching. I've read the papers. I mean, there are papers in Science. There's in the American Journal of Human Genetics recently about your programs. I mean, it isn't just like you're talking about this. You've got the data. It's extraordinary, and you're really contributing to the academic side too. Now, one last thing I want to ask you about is, can you do this in Danville and in Scranton? What about America? Can you do this? Can this be the model for America?
So Atlantic City has the diversity that exactly matches America, which we didn't know. We're in Atlantic City, and we're doing it in Atlantic City. So oftentimes I think the criticism or the questioning of a place like Geisinger is, it works up there where no one moves, and you've had an electronic health record, and you got all the pieces. Yeah, we could do it too. We're doing it in a real robust city that's had its own ups and downs. Our Atlantic City platform basically said when all the casinos were closing, they're reopening now. There's a couple new casinos there. But when the casinos were closing a few years ago, they said to all the casino workers, we'll provide you healthcare for the year for free. So it's been that same kind of engagement with the community, and then hopefully the community comes back, and we're seeing it back in Atlantic City. And that's a place that does not look like Danville, Pennsylvania. It looks like America.
All right. It's amazing. I mean, I think everyone that's listening or reading this transcript will be actually stunned, because so many are not familiar with the pioneering efforts that you're doing. So congratulations on that. We're going to continue to be watching what's going on there and hoping that it expands geographically. I don't know what more innovatively you can do, but you are as disruptive in a positive way as anyone there is in all of healthcare at Geisinger. So with great admiration, David, to you and all your colleagues there, we're cheering for you. So thanks so much for joining us today at Medscape. And I know this will be enlightening for everyone who's learning more about what's going on at Geisinger. Thanks, David.
Thank you so much, Eric. It's been a real pleasure.